Hello, and welcome to the CAP Today webinar for Wednesday, the 1st of June. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentations. Today's webinar is entitled Advancing Diagnosis and Management of Viral Infections in Transplant Patients. This very important webinar has been made possible by a special educational grant from Hologic, and we certainly want to acknowledge and thank Hologic because it's through their help, in great part, that it allows us to bring you this very important program. We have two speakers today. I'll say more about each one in due course. Our first speaker today will be Dr. Belinda Yen-Lieberman. She is of the Cleveland Clinic and the Lerner College of Medicine at Case Western Reserve University. And our second speaker will be Dr. Amorce Lima, who's a PhD and a clinical scientist at the Tampa General Hospital. But before we begin, I do, as always, have some housekeeping tips that I think will improve your experience. We often suggest that you refresh your browser. That helps keep you optimally synced with slides and audio. We have live help available at any time during today's webinar. At the bottom right-hand corner of your screen, you'll see the number 858-345-5916. You can call and get help. You'll also see at the bottom of your left-hand side of the screen a box labeled Q&A. You can also make technical remarks here. If you're having trouble with a website, having trouble with audio, just type that in, and then we will be able to answer that. And we'll take our presentation sign down so that that box is fully open for you. Thank you. But of course, the Q&A box is primarily for your comments and questions for our presenters of today's program. As I said before, we will get to those questions and comments after they finish their presentations. You'll see the full slides and audio of today's webinar in about a week. It'll be complete online at captodayonline.com. So that's a great resource for you for review and also for sharing. Yeah, I wanted you to know that you'll also see some follow-up email from ourselves and from our sponsor, so that's all quite to be expected. And finally, as always, I want you to know that CAP Today does not endorse any product or service that may be mentioned in today's webinar. And of course, any comments that I make are purely personal, not to be taken as policy of the CAP Today or the College of American Pathologists. And with that, then, let's begin our formal presentation. As I mentioned before, our first speaker is Dr. Belinda Yen-Lieberman. Dr. Lieberman is a professor of pathology. She's on the consultant staff on R&D in Clinical Virology and Infectious Diseases Serology at the Cleveland Clinic and the Lerner College of Medicine of Case Western Reserve University. It's a great delight to welcome such a great expert, and I'll ask her to begin her presentation now.
Thank you. Good afternoon, everyone. I want to share with you some personal experience regarding to management and diagnosis of transplant viruses. Some of the most common viral infections in transplant viruses are usually CMV, EBV, BK. In the lab, actually, we call these three viruses the transplant viruses for the sake of us testing in our lab. So CMV stands for cytomegalovirus. The CMV remains as one of the most common complications affecting transplant recipients with significant mortality and occasionally morbidity. So I want to start with giving you a little bit background. So CMV is a DNA virus. It's a member of the herpes group. We call them herpes viridae. In this group, there's some famous viruses like herpes 1, herpes 2, VZV, those are the chickenpox virus, and EBV, that's the virus cause you have mononucleosis when you're in college. and then herpes 6, 7, 8. The most important one we're going to discuss here is the CMV. In immunocompetent hosts, most of CMV infections are mild and self-limiting and no symptom at all. And then based on WHO, CDC's estimate, between 50 to 80% of adults have had CMV by using antibody test screening. I don't know how many screening across the country. So I remember I went as a volunteer to get tested, and I was CMV IgG positive. Majority of these viruses are known for establishing what we call latency, which possess high prevalence rate and causing disease immunocompromised hosts. What's latency? So the virus enter your body, they're in dormant, and then you feel perfectly fine. When, for whatever reason, it be a transplant, HIV, or sometimes you stay up 7 days study, you're very tired, you're really weak, and this will come out. The best example is when you study exam in college, suddenly you have a little lip blister, we always say, well, that's the herpes. So that's what the latency virus it's unique, and then they can stay in your body, and no one ever been say, can you ever be cured, like the chicken pox? Once you have it forever. And the only time come out when you're not healthy. So a little bit on CMV disease. The CMV infection is potentially life-threatening for the immunocompromised patient. Immunocompromised patient with mentioned already transplant. But still it's very common. And there's no, I would not say there's no cure. However, when people have the post-transplant, there are a lot of drugs for this. So CMV disease from transplant recipient. And the evidence of CMV, in infection with symptoms, fever, malaise, and then usually it's very common when you post, solid organ transplant. And then usually present this and then just keep there until it become very serious, and then you get treated. So we call definition of CMV disease is when you have the CMV infection, means you have a virus, no symptom, then you start having symptoms like fever, malaise, and hepatitis or even pneumonitis. So the risk of the CMV disease is the highest during the transplant surgery. The donor is antibody positive, CMV IgG. The recipient is negative. This is the worst. However, we all know very rarely you're lucky you can get enough donor that's CMV negative. So that's why most of the ID doc all prepare big time with a variety of drugs to keep patients healthy, because they notice the patients D positive are negative. And because usually people don't have any humoral immunity or lack of cellular immunity, and most of the time they are being treated with multiple drugs. So now get into the most important part of this talk is what do you do? How do you measure? So a little bit overview of the CMV assays. So CMV assay, the CMV serology, the test for antibody, should be performed pre-transplant, and both organ donors and the recipients every time before the surgery. At our institute, when the donor arrives, we also test HIV, HPV, HCV, all those, just to more preventive, more sure. So the lab usually are very busy. They want the only viral load for the HIV, HPV, HCV. So we do this kind of test 24/7 in order to keep the patient not be waiting. So serology has the CMV IgG and CMV IgM. Many other tests, they even have IgG, IgM, both CMV. For this case, for the transplant, the CMV IgG is the most important test because it is more specific. The specificity is very high and not IgM. Therefore, just be sure of the importance of the IgG for specificity for your patient that has CMV disease. So CMV antigen test, the second one, I believe this test we were doing that 10 years ago. It's called CMV PP65 antigen. What's that? The PP antigen is a pyrophosphate protein on the surface of a virus, CMV. Where do we find the virus, CMV, in the patient? In the lymphocyte. So many times to detect PP65 antigen, this is before RT-PCR or the automated molecular tests are available. We're doing patient's blood will come to the lab. You prepare smears, and then smears. You fix the smears. You use either immunofluorescent. A lot of other people use hybridization. One or the other, you're looking for the viral, viral protein, or some people think the viral nucleic acid could be there. You detect the presence there on the smear. The problem is, in the big hospital, you never get your blood in 4 to 6 hours. And also, many of our patients discharge, they draw the blood, they send to us. That's way too late. So when we did that, this PP65 never worked too well. So when we did it, we actually make sure the fellow resident will run over to the lab. But that didn't last very long because they can't do that all the time. So the sensitivity, specificity is sensitive, is positive, but we were having trouble to keep up. When we compare PP65 later on with PCR, and there's no comparison. So that moved on to the molecular test. The last decade, molecular tests, the preliminary chain reaction PCR or real-time PCR just took over, took over all the very labor-intense, less sensitive tests. So the molecular CMV DNA quantity test becomes the routine test for all of us. And just to be sure, everyone who's listened to this, so the company has been very, very good, smart. Now a lot of tests are automated, so we never have to worry about take the blood, take a 500 microliter extract. So now all the tests go, the tube come in, you barcode, you stick in the machine, remove the lid, shift in the machine, and then push the green button. It just keeps going. So nowadays we hired 20-some technicians to do the COVID test, and then they just call the machine plug and play. So anyone, you have 2 fingers, you're a nice hand, you can do this test, which really significant increase, advantage for all the clinical lab. I'm sure whoever is doing that, just be thankful. And the results go out by, unidirection. So going to the epic, going to the clinician, we never have to review whether the positive, negative comes. So as a result, so most of virology lab, very few molecular tests are being offered because it's too difficult the other way. In the case you have tissue, invasive tissue, and we even can take the tissue and doing PCR instead of in situ hybridization. So we have tried some of that in the research project. We also take in the bronchial lavage for the patient has a lung part. We take the fluid and did the real-time PCR. So eventually, when it's positive, and getting this molecular diagnostic test is FDA cleared, and then it's just a safe, not only sensitivity specific, but it's much better, more accurate, and more faster for clinicians. And so the tissue invasive test, we take over the famously called fish fluorescent in situ hybridization. So we are very happy the last, I would say, almost 8-9 years. So quickly, importance of monitor viral infection in transplant patients. Well, why do you need to do that? Once you give patient the organ, transplant organ, you load the patient with a lot of immunosuppressor drugs to prevent the patient reject the organ. Now the patient is very weak, and then all of them are easily be infected. Just you whip something passing by, we use the joke, they'll get it. So you get really, really concerned the risk of the patient plus, doing the viral load. So molecular test is really the standard care. So we do actually at 0 time before the surgery, we do the day one, first week. I think when I count the last time, first week, we did at least 4 to 5 CMV viral load. And since we use all molecular diagnostic, automated machine, we were able to give our result because we have a 3 shift. People come at 8 o'clock, and they come at 2 o'clock, they come at 11. So every 4 hours, 4 or 5 maybe, the result automatically go out. At where we work, the result not only go out, they actually go on. We have 15 people. They are very responsible with all the solid organ and bone marrow organ. They have their result text to their iPhone, so the floor nurses and the clinician can take action. When we only text the result to them when the patient viral load results greater than 50,000 IU per cc. So that really saved a lot of people, hopefully a lot of lives. So how do viral? Just mentioned when we use it, but how are viral load tests used clinically? This is a clinician. This is we have a meeting every month with clinicians. So they make a decision how to initiate preemptive therapy. So how do they do that? The minute patient has the surgery, they will do very quick viral load. If they suddenly become positive, they initiate. So become a very, very important step. And then also when to initiate prophylaxis, all your patients be transplanted, all of them have risk, then everybody get treatment. So this called prophylaxis, a lot of people call universal prophylaxis treatment. And then also you monitor. Once you start your patient, you go through your rounds, you look at the patient, you want to know how they're doing, viral load. So you want to know, did my drug work, or is the patient virus load going up, virus load going down? So this is crucial. So the first month probably is the most important part for a very severe surgery, and determine the duration of therapy. If you follow the patient viral load, after a little while, the viral load is 1,000,000, 500, 200, going real low, and then you know when to stop. So by doing that, the clinician can really access the prognosis of the patient by using viral load be the guide to tell them where we are, how the patient doing, how that relate with the symptoms, fever, malaria, all that. So this is a very important clinical decision. The important now, we're talking about standardization. There's so many labs, thousands of labs doing this viral load. How do I know your viral load same from mine, my one same from my friend in Toronto? So we call it commutability. The patient sample and the calibrators, that's the WHO international standard we all have to purchase using all the rounds. So patient sample and the calibrator test at the same time, and you want to see the result of your patient sample and the result of the standard calibrator are the same, no matter what machine you're using and how you do it, how much you use, so whether you have an automated extractor or not. So this commutability is very important to know your result is acceptable and is agreeable among all the people using it. Harmonization is sort of the same thing. So, and the clinical lab result means results are comparable. No matter what you use, procedure you use, where you use, when do you use, the results should be all agreeable. And then viral load threshold. This is very interesting. So universal threshold viral load for predicting disease cannot be established because there's so many labs, so many people, age, and different kind of transplant. It's impossible to set a guideline. So when we did ours, we did adult kidney and heart transplant. Kidney and liver transplant, and with our ID doc and group of ID doc, we follow for 1 or 2 years, and then at that point they call me and say, oh, Belinda, we decided 50, at that time we used viral load, we used 50,000 copies. I said, how did you do it? We checked with the chemistry and also their symptoms, how well the patient doing. We feel whenever beyond that is really severe. So every time we get a 50,000 at that time, we will do page them, regardless even their iPhone beep or not. We page them to alert them because they will feel very, very scary, pretty close to death happen on some weak patient. So the viral load threshold should be decided by different institute, different patient, and it's really hard to really have a universal guideline. And then there's a guideline, the international consensus guideline on the management of CMV, which I advise anyone who's interested and to take a look at this. Very, very useful. So how standardization, harmonization, viral result proof? I can show you some example, but this is everything be based on WHO internal standard, and then you only report out the viral load as international unit. So your IU is different. It's the same as the IU in France and China, all the places, so everyone can speak the same, language, which is very, very. So I would say 5 years ago, maybe 4 years ago, we changed everything: HIV, BC, and then CMV, EBV, and BK. They're all IU per cc. And then also from the recent publication, really, really good publication is they found out that where you can improve your designing the test by the size of amplicon. So they have really good publication, I think it's 2018, showing when those are doing laboratory developed, they can design the amplicon smaller and still cover the important part of the virus sequence. Then you can have your test go up to 10 million IU per cc. So now when I go look, most of the IUs can go up more than a million, and then some of them, FDA approved. So this is most of this FDA approved test has been all validated. So in our place, when we get a new test, we validate all this about. Usually take 2.5 months to validate the whole thing to move a new test onto our machine. So some example, variability of, so what's the big deal, laboratory developed IVD? We all know, I was told if you're a lab director, if there's FDA approved test in this group, you have to do it. Otherwise, you're not getting reimbursed. That's what I was told. But of course, by looking the result, the study from this group, the left side of this figure showing with all this lab, they all do the same dilution. You have 6 lab. Notice how close they are. They are like totally identical. And then they're using just one test and the same dilution. Good. But if you go to the right side, you all have your laboratory developed test, but you're still doing the same thing. You can see how difference on the viral load can make a lot of difference when you decide to treat or someone initially infected or someone is getting better. So it's important. I just think it's important whatever you do, you based on the international unit. And this next slide is very important. Standardization with consensus calibrator. You reduce variability, quantitation, CM. This is very important for all the lab. I don't care what virus they do, especially the virus clinician use to decide how to treat the patient. Same thing on the left side. Before the WHO international standards used, and the 6 lab or 7 lab, you can see, and they can use their own calibrator. You see how nice they done, but they all spread 5.5, 7.5. But when now everyone going to do the same thing, and everyone, you can see the right diagram is beautiful. So your viral load and your hospital next door or down the street, the viral load should be the same. So this is very important for any lab who are using quantitative viral load result and to follow in order to have a better practice for your clinician. And I already mentioned that I think it was in 2018. They were showing when you use a smaller fragment, the CMV amplicon, you can carry your test up to 10 million. So on the left side, it's 52 base pair. All the way use the big amplicon, and then 340, you can see the difference in how far their standard can go. So that was very, very important. I also know our commercial company, they already did it before I even found out what they did. So again, LDT versus IVD for CMV virus testing, and then I think most people on this call probably will know when you do validation and then you establish performance, and then but when you have an IVD, you just do a verification. It's just analytical accuracy, precision, this. But when you do laboratory developed and the LOD, you can see the long list of things you have to do to become LDT. And then also very variable. We tried LDT 10 years ago. The reagent, we don't know how long should we keep them. So we didn't do anything for 6 months. The result was so different. And that really taught me a lesson a long time ago. I said, until we can do what the FDA approved the test, we really should not use this quantitative LDT test seriously to your patient to treat your doctor to treat the patient. So, conclusion, the CMV is among the most significant pathogen for patient post-transplant. Anyone, including bone marrow, everything. Quantitative nucleic acid test is really the current gold standard so far I'm concerned to monitor CMV, how much CMV viral in your patient, what should you do? And without that, it's very hard for you to treat patients. The CMV viral load used to start treatment. If you test patients that have no virus, don't treat, type of thing. And then you monitor response, we already talked about, follow them, and then I think at Cleveland Clinic we have a PharmD stewardship. They will show me 3 months the curve to show the patient why they are doing so well. The curve went down. So it's very, very important to monitor the health of your patient. And then the prognosis, of course, is the same thing I'm just saying. If the viral is gone, you're treating well, viral is negative for the next 3 times, they're done, they're cured. So it's essential you have to standardize the sample to answer, and commercial tests become a lot more available. I can tell you if I don't have the automated test, I will not be able to do 6,000 COVID tests every day. We did a 3 shift. We will be not having the job. So I think we rely on the commercial company and on us to do our homework, follow their guidelines, do a good practice. So anyway, I will stop here, and this is the end of my talk.
Dr. Yen-Lieberman, thank you so very much for a wonderful talk. I want to remind the audience now that they can ask a question or make a comment anytime by typing in the Q&A box. There's certainly a lot of food for thought here and a lot of interesting data points in your CMV testing program at the Cleveland Clinic. So we thank you for that, and we'll be back to you after our second speaker finishes. And that speaker is Dr. Amorce Lima. He's a PhD and also microbiology credentialed with the ASCP. He's a clinical scientist in the Esoteric testing lab at the Tampa General Hospital in Tampa. And I will invite Dr. Lima to begin his presentation now.
Thank you, Bob. Appreciate it. As Bob mentioned, my name is Amorce Lima, clinical scientist in the Esoteric Research Lab at Tampa General Hospital. I will spend a little bit of time in the first few slides and talk a little bit about Tampa General Hospital and the clinical lab here and what we're doing here at TGH.
Dr. Lima, just 1 second while we get your slide deck loaded here.
Okay.
Can we do that, please?
While they're doing that, I want to say that the Esoteric testing department is part of the clinical lab at Tampa General Hospital, which is a big lab that has all the common departments that you would normally see in a major hospital lab. The Esoteric department was pioneered by Dr. Ray Wyden, that many of you might have known, who unfortunately passed away a few years ago. In that lab, we have the molecular testing part of the Esoteric lab, and the molecular testing folks do all the molecular infectious disease testing. And we have also the flow cytometry part of the Esoteric lab, who does the oncology testing and the research and development part of the Esoteric lab, which I'm a part of. We do a lot of assay development and validation, also industry-sponsored clinical studies for 510K submission. We also have a bunch of, we also save specimen, we biobank specimen for validation, as well as to partner with industries for clinical studies. There's also another lab here that actually specifically do a lot of transplant testing for the clinic. And this lab is led by Gene Smith, so they're doing a pretty good job there as part of the transplant clinic here at TGH. So we were very, very pleased.
Excuse me one moment, Dr. Lima. Can you advance your slides for us, please?
Yes.
There we go.
Okay.
Are you on the right
slide? I was still in the first slide. So basically, we were very pleased to actually partner with Hologic to do the analytical and clinical performance evaluation of the CMV quant assay in plasma and non-plasma samples here at TGH. So for my part, we'll just go over the data in a few slides. So if you actually live in the Tampa Bay area, you would hear that a lot, that Tampa General other hospitals practice medicine, but we define it. So that model will actually derive from our vision and the big why. Why do we do what we do? So we want to be the safest and most innovative academic health center system in the United States, in America. What is it that we do? We heal, we teach, we innovate, we care for everyone every day. When we say everyone, we mean everyone, whether or not that person is mildly sick or very sick. So we would care for the patient, whether or not the patient can pay for their care or not. We provide care for the patient as we would do for everyone. And the hospital is a big hospital of over 1,000 beds and more than 8,000 employees. And we are the primary teaching hospital for the University of South Florida Mosani Health College of Medicine. And we are recognized for the world-class care that we provide in this area. We are known as the number one hospital in Tampa Bay, rated by the U.S. News report in 2021. We are in the top 10 in the nation in patient care for cancer care, neurology, neurosurgery, pulmonary, and pulmonology, as well as lung surgery. We also have other specialties such as internal medicine, cardiovascular, orthopedics, ENT, and so on. We are one of the leading and busiest transplant program in the United States. So these data here in that slide show that the number of solid organ transplant that we performed here at TGH last year. So as you can see, we performed over 550 transplant last year. 330 of them were kidney transplant. Over 140 something were liver, 48 lung, 26 heart, and also kidney and pancreas transplant as well. And we have been ranked the number 3 in the nation by volume for kidney transplant from both adults and pediatrics. Now, organ transplant is a life-saving treatment for patients with end-stage organ failure. Statistics have shown that more than 20 people have died each day waiting for transplant. But there are good news. last year, 2021, sets an all-time record for organ transplant and organ donation from deceased donors. There were more than 41 organ transplants performed last year in the United States, which is an increase of close to 6% from the previous year. There's also been a record of number of kidney and heart and liver transplant as well. Even then, there are some challenges that the patients still face with post-transplantation uncertainty, the uncertain outcome after transplantation, post-transplantation infection, as Dr. Lieberman had just talked about, and as well as organ failure. So I'm not going to go through this. Dr. Lieberman has talked about it. So just want to say that there are several different viruses that are associated with post-transplant infection. The most common with one is CMV, and there are others as well, BK, VZV. So we test for all those different viruses as well here at TGH in transplant patients. This slide actually highlights the number of tests that we perform per month. Just to note that those tests are not all from transplant patients. This gives you a pretty general idea of the number of testing that we're doing per month as far as those viruses. CMV, more than 900 a month. BK, 700. EBV, about 225. VZV, 30. Adenovirus, 20. Even some of the HSV as well. We're seeing at least 6% of HSV in transplant patients per month. And as we mentioned earlier, Dr. Will Wyden was the one who pioneered the Esoteric testing lab, and asking the question, how far have we come? So in the beginning, we had a lot of lab-developed tests where we do a lot of manual extraction and manual conventional PCR amplification using gel detection and enzyme-like hybridization to detect the results. From there, we moved to automated extraction on the EasyMag and use the water gene real-time PCR amplification. Then move into automated extraction and PCR, where you get go from sample to answer. So we used to do all of this. That was the turnaround time used to be days, several days, and that moved to a few hours. And as we go to automated system, we move to a system that can do all of those testing within a couple of hours or so. So that's how far we've come. And we also have a lot of different platforms that we use in our lab. The BioFire, we use this for large panels like GI panel, meningitis panel, and our P2.1. We have the GeneXpert, where we use it for SARS-CoV-2 single testing, as well as the multiplex, the fourplex, or the flu, RSV, and SARS-CoV-2 on there. And the ASTRON instrument, where we do a lot of viral testing and quant as well. We have the ELITech, which we currently do the CMVS or assay on that. We also have the Hologic Panther system. We do the STI on that system. We have the VidiMax, in which we use for MRSA, Mycobacteria, GBS. We have the Belinda Yen-Lieberman for SARS-CoV-2. And we have the pneumatics instrument as well, in which we do SARS-CoV-2, as well as the fourplex for SARS-CoV-2, flu A, B, RSV. And we also have the Illumina sequencing platforms, the NextSeq, the MySeq, in which we do SARS-CoV-2 sequencing, and the iSeq, the little guy that we use for bacteria sequencing and for HAIs, which we serve not only the hospital here at TGH, but also all the hospitals in the area for infection prevention control. Now, we were very excited to partner with Hologic to work on this study. As you know, we have a big lab, a big hospital, so we don't really marry to any platform or company per se. So we always look for ways to improve our testing capability so that we can provide our patient with the best care possible. So we're very excited to partner with Hologic to work on this study. And the objective of that study was to evaluate the Optima CMV quant assay for the detection and quantification of the CMV on the Panther automated system. At that point, it was the investigational use only. But earlier this month, they had gotten the FDA approval for that assay. So we are very excited and congratulations to them. Maybe some of you have already known about it. But the second objective of this of the study was to compare the results obtained from that, from the Optima CMV quant assay, and compare it to the standard of care that we currently had in the lab, the ELITech MGB CMV ASR, which is done on the ELITech InGenius automated system. First, we wanted to put that disclaimer there just to say that we only use with your specimen in that study, and the study was conducted in compliance with the IRB approved protocol, good clinical practice, and other requirements pertinent to in vitro molecular testing devices. As far as the analytical performance, we tested for the accuracy of the assay using the CRK AccuTrack CMV DNA quant panel, and the linearity of the assay was assessed using the exact diagnostic CMV verification panel at different concentration, going from 2.6 log IU per ml to 6.6 IU per ml. The limit of detection of the assay was determined using the exact diagnostic CMV verification panel at different concentration where 5 replicates of each of the concentration was used were tested. So as you can see, the linearity result show pretty nice linearity across the range of the test. On the y-axis, you have the Optima CMV results given in log IU per ml, and the expected values are on the x-axis. So you can see a pretty nice line and very good slope and squared values. And the same was seen also for the ELITech CMV assays versus the expected. So you could see there's pretty good correlation between them. Same thing was seen as well for the accuracy data, which CRK AccuTrack panel was used. Very nice slope and R squared for both the Optima and the InGenius CMV comparing to the expected values values gotten for those samples for the from the panel. Next, we wanted to look a little bit further in terms of the raw data for the accuracy results. As you could see, those samples were tested in duplicate. This column here is the expected values. This is the ELITech CMV results. The next one is the Optima. Next one is the difference between the ELITech and the expected values from the panel. Then Optima and the expected values from the panel. And this one was the difference between the quant values for each of the samples between the Optima and the ELITech. So what we are seeing on the bottom is the mean log difference between the ELITech and what's expected, which is the value is almost 0.6 log, showing that the ELITech is quantifying those samples at least 0.5 log higher than what was expected from the panel. And whereas the Optima is quantifying those samples at an average of 0.14 log IU per ml. And the difference between the mean difference between the Optima and ELITech is almost 0.5 log, which means that the ELITech is quantifying those samples at an average of 0.5 log higher than the Optima assay. So just keep that in mind, because we're going to revisit that toward the end when we talk about the clinical results. We also looked at the limit of detection. So the limit of detection has shown that, as you can see here, there's a little discrepancy in terms of the number of replicates that were used for the limit of detection for the Optima versus the ELITech assay. The reason is we wanted to use about the same number of replicates. What happened was that when those replicates were, when those samples were diluted with Optima buffer, the ELITech instrument didn't like them, so it didn't amplify them even, it didn't detect them even at 200 IU per ml. So basically we had to order a new set of panel and dilute them in water, and had to retest those. And even then, because of the limit of the number of samples that could be run on the ELITech, which is up to 12, we couldn't run as many as we would like to run. So basically, that's why the discrepancy is here. But our focus was mainly on the CMV LOD, so showing at least 19/20. At that point, we get at 95%, we get an LOD of 50 IU per ml. So that shows the LOD of that assay is 50 IU per ml. Versus here, we have 200 IU per ml at 95% detection. But in there, they have reported, like the ELITech have been reported that their LOD is around 100. So that's where we are as far as that. And from the analytical performance, we wanted to look at how the assay is doing using clinical samples. So we tested the agreement between the two assays using 249 clinical samples. Out of those 249 samples, 141 of them were retrospective frozen samples, and 108 of them were fresh samples. And the fresh samples were, the frozen samples were kept for the study, and the fresh samples were tested after the standard of care was done testing. And out of those 249 samples, 217 of them were plasma samples, and the 32 of them were non-plasma samples, including respiratory samples, ocular and GI, and congenital samples. So this slide here show the first part of that slide on the top here, showing out of the 217 plasma samples that were tested, 134 of them were detected by both methods, and 66 of them were not detected. So there were 17 samples that were discrepant, and all the samples that were discrepant, they were near the limit of quantification of the assay, and the Optima assay detected 13 of them, whereas the ELITech assay only detected 4. So we have a 97.1 positive percent agreement between the two assays, and a negative percent agreement was in 83.5, and overall agreement was 92.2 within the 95% confidence interval. The non-plasma samples, all of them, there were 32 of them, 26 of them, there were 100% agreement. 26 of them were detected by both assays, and 6 of them were not detected. So in assessing the clinical correlation between the two methods for the plasma samples, the Deming regression analysis here, as you can see on the left, shows a very nice slope of 1.0 and a good R-square value of 0.88, demonstrating a good correlation between the two methods. We also used the blend-augment plot to actually further investigate the correlation between the two assays. As you could see on the right, And in this plot, the differences between the quant numbers for each samples were plotted against the means of the two measurements. So you can see the negative bias here is at minus 0.5 log IU per ml. And we can see that the bias is not really due to any particular range. As you could see throughout the whole data, range within the agreement intervals, which were 95% of the difference. You could see that all the samples fall within that 95% difference between the two methods. So what the Blotman-Ullman analysis is showing that the ELITech ASR assay is quantifying the samples at an average of 0.5 log IU per ml higher than the Optima assay. So we had also mentioned that earlier, even in the analytical performance, that the ELITech assay was quantifying the panel at 0.6, close to 0.6 log IU per ml. And I believe Dr. Lieberman also alluded to that being an ASR and also the difference between the LDT lab. There could be that huge difference, in quantifying those samples, and also the InGenius assay is known to the target for that particular assay is small. The target is small. So Dr. Lieberman also alluded to that could be a reason why we're seeing this here in the ELITech assay as well. So the advantages and disadvantages that we've noticed between the two platforms. The Optima CMV assay on the Hologic Panther. The Hologic Panther is random access, true random access, where we could actually add samples whenever we want as the samples come in. There's a broad assay menu as well versus the ELITech, where you have to batch the samples to actually really take advantage of the test. And the reagent for Hologic Panther are ready to go. Versus you have to make up your own reagent for the ELITech assay, leading to higher hands-on time for the ELITech assay versus the shorter hands-on time and faster turnaround time on the Hologic Panther. And the Hologic Panther, the throughput for that instrument is much higher. 36 samples can be run in 3 hours. Versus 36 in 11 hours because of the fact that you can actually load up to 12 at a time, plus the hands-on time as well. So the only disadvantage that we can say about the Hologic Panther is the higher volume of sample volume, which is 700 microliters, although the instrument actually pipette 500 for the assay, and the 200 remaining samples can be used for other purposes. Versus the ELITech using only 200 microliters starting volume. So in conclusion, we've seen great overall agreement between the two assays, the CMV quant assay versus the ELITech MGB OLED CMV ASR assay, and very nice clinical analytical performance with nice linearity and accuracy with a very low LOD of 50 IU per ml for the CMV assay. For the Optima CMV assay, and there were some discrepant samples, but those were near the LLOQ, with most of them detected by the Optima CMV assay versus just a few detected by the MGB OLED CMV ASR assay. Again, something to keep in mind that there's a difference of 0.5 log IU per ml, that the ELITech is quantifying the samples much higher, the higher log IU per ml than the Optima CMV assay. We also talk about the benefits where the Optima CMV assay on the Panther being a random access instrument, ready to use reagent, lowering the turnaround time and giving you a higher throughput than the InGenius system. So with that, I want to thank the lab at TGH, the molecular team, as well as the research team, specifically to Vicky Hiller and Laura, who have dedicated a lot of time running the assays and collecting the data. Also, a big thank you to Susan Silbert, our scientific director, who lead our lab. Thank you for your time.
Dr. Lima, thank you very much for a great presentation, and it's always a pleasure to review all the wonderful things that are done at the Tampa General Hospital. We have a few minutes left, and we'll get to as many questions and comments as we can. Dr. Yen-Lieberman, you're still on, aren't you?
Yes, I'm still on.
Okay, so I'm going to direct the first question to you.
Yeah.
Someone raised this very quickly. What about avidity testing? Can you comment on avidity testing?
Yeah, sure. Avidity is to show how well the antibody, when contacts the antigen, the strength, how nicely they bind and then make the test better. So in the clinical lab, since our test is all FDA cleared and it's automated, I'm afraid that at the beginning when we validate the test, we were unable to see how they bind. The antibody binds the antigen. And the only thing we can do is we use our serum and get the commercial cleared, let's say, antigen, and then we test negative with our assay, look for negative or equivocal, and see if it come out the same thing. That was the only little thing we can do. When we do validation in the lab, unfortunately, this is not really serology, special lab. We are molecular virology. So as a result, we were doing binding of some negative particles. I joked about that. We could not get any answer. But I assume in the serology lab, a long time ago I was involved, is they actually take sample, incubate together and measure, see the binding. We are not, I'm sorry, we are not doing that, so I cannot really say, oh, we did it. But I assume most of the place has to do it before they can really perform how well is their antibody test.
Thank you. Thank you very much.
I can do the second
Dr.
one.
Lima, I want to give you a chance to answer a question. We've had several regarding the ideal specimen types. One talks about, is there a rationale to use whole blood over plasma for CMV viral load testing?
Good question. We did both, okay? Because we are thinking if you use plasma, you already spun down. That's my being a virologist. You how do you get plasma? You take the blood spun down. So you really measure the virus that's free from the lymphocyte where the virus is supposed to grow. So we did a plasma, and we take a sample, split in two. One did the whole blood, the other one spun down, used the plasma. We did several rounds showing the viral load in the blood. It's a little bit more than the viral load in the plasma. So I was telling the people in the lab, I said, I told you the virus lives in the cell. When you spin it down, you're going to lose some. So we did it for a year, but it's very painful, right? A whole blood, easy. Give me the blood, I put it in the machine. Now plasma, you have to go spun down, re-aliquot. So I did a whole blood for a whole year. Then we did a series test, side by side, 200. They are different, so the viral load in the whole blood, it's a little bit different from plasma, a little bit more, but was not clinical significant. And then my technician will look at me like, can we just use plasma now? Because we were moving to an automated system. They only use plasma. So we voted and they were right. So in life, even though I thought serology, is not what the virus is, it should be in the cell. It's correct, but it's not useful. So we switched everything a year ago to plasma. It's easy, and it's easy to do. The difference, it was very little difference in viral load. So we were happy with our lab complete switch to plasma about a year ago.
Very good. Thank you. Let me just ask Dr. Lima one last question here. Is it better, in your opinion, to report CMV results in international units per ml or log international units per ml? Dr. Lima.
Believe in our lab. I mean, we're looking at the results. I mean, we do send them as just like IU per ml instead of log IU per ml. I don't know. I guess it depends on the labs and how the clinical doctor would like to get the results. But in our lab, I believe it's IU per ml. That's what we report.
And let me ask Dr. Yen-Lieberman to answer the same question. Better to report in IU per ml or log IU per ml?
We at the very beginning we did it, and the clinician didn't like it, so we put the viral load and the IU. We put the parenthesis log. So once they got used to what's log 1, they said, okay, get rid of that. We don't need that anymore. So we let them have it both. It's it's electronic. So we did it for 6 months. They said, now it's very confusing, your log. Just give me the IU. So we did it both for a while.
Okay, that's two very good answers, and I hope that resolves the question there. With that, I'm going to give you the last word, Dr. Yen-Lieberman, and begin to wind up today's webinar. So I want to obviously thank Dr. Amorce Lima, Dr. Belinda Yen-Lieberman. I particularly want to thank Hologic. They've been wonderful partners for many years with us, and particularly this webinar today is made possible through their special educational grant. Finally, as always, I want to thank all of you in the audience who are participating with us. I recognize many names. I hope to see you all a week from Friday or Saturday in Washington, D.C. at the ASM. We'll be live, and it should be a great, great pleasure. Looking forward to that. So with that, once again, I want to thank Dr. Yen-Lieberman, Dr. Lima, Hologic, and all of you. And with that, this is Bob McGonnagle, and I'll bring the webinar now to an end.